when you actually look socioeconomically in India, the real travesty is that if you look at today the population and where they're centered, if you would, within India based on income levels, and you start to see the burgeoning middle class that now grows to 820 million out in 2015, look at the prevalence of this disease as it reaches out there. We're talking in excess of 18 or 20%. So how do we combat that? There aren't enough doctors. If we could clone Dr. Mohan, and if we could clone him in every possible way and put him in everybody's pocket, we could solve the problem, but we can't do that. We need to have solutions that are configurable and customizable. Two very critical elements. What works for me may not work for somebody else because of my medication history, my medical history, my own preferences, fears, knowledge of how to manage the disease, etc. And of course, it can't just be cut and paste from the West. We can't take things that work in the USA, Canada, etc., and just cut and paste them here. They won't work. They have to be culturally optimized.
So what is kind of really interesting is that there are kind of two very interesting complementary technology or complementers that are being developed around the same time, which will help this. One is this emergence of the widespread use of mobile phones. So if you can make any type of a software program that is kind of not kind of prohibitively expensive and can be easily kind of implanted in a mobile phone, that will kind of really help. Second one is, of course, the Nandan's implementation of the unique ID project. These are all kind of the application of technology to what is happening right today. But as the system kind of develops, you can also think of one day where you can actually implant kind of a whole pharmacy within a patient's body. Of course, that's probably going to happen over the next maybe 10, 20 years. But there are several things that mobile technology can do, kind of what's happening today.
For us, we are scouting around, we are looking around for opportunities to work closely with technology partners how we can address the tremendous opportunities in M-Health. And from our perspective, we've identified 6 opportunities, 6 areas. Let me take you through the 6 one by one. There's remote diagnostic and telemedicine. There's remote monitoring and compliance management, emergency response and care for elderly, education and awareness, lifestyle, and administrative and miscellaneous. The first one, the remote diagnostics and telemedicine. And here, what we are working on is we're following a hub and spoke model with hospitals. Very good solution and pioneering work. But there are lots of challenges. What we are finding here. One big challenge what we find here is the acceptance in the tier 1 cities, smaller cities like Jaipur, Lucknow, Bhopal. We are finding that the acceptance there is much higher. But cities like Delhi and Bombay, we are finding the acceptance much more difficult. And the other challenge, what we find is the acceptance, the sort of a mindset of the doctors. Accepting new technology or a newer way of doing things.
My interest in healthcare is primarily related to really more coming as a consumer, from a passionate standpoint, as well as from a business standpoint. So there's three takeaways that I'd like you to leave with you. One of the things we heard in the conference yesterday was, can innovation, India has done a lot of interesting work, but can innovation really come from the East? And even if innovation came from the East, i.e. from India or some of these countries, how about reverse innovation? Do we have the capacity, the capability to take it back? So it actually starts getting leveraged in even the Western market. So we actually think in Cisco we're on a journey to potentially do that. When I moved here about 2.5 years ago, we actually spent a lot of time with many both health providers, consumers, insurance companies, and said, if we had pixie dust, we could do anything. In terms of solving the access to healthcare, what would the characteristics of that solution look like? Primarily came to 3 things. One, they wanted a technology to be truly pervasive. The second key requirement, really, as you see on the right-hand side, was people said, it's nice if you can do pilots and experiments, but we need something scalable. The third key thing, which I think is very unique to India, is, in West, and I spend half my life in India and half in the West. In West, typically people look for best of breed, right? In India, it's interesting, people want truly an end-to-end solution. They say, you know, even though you may not play in that particular space, we don't have an HIS system. Or if we do, make sure it integrates. So that was the one key point I wanted to make, which is innovation is possible if, you know, if you are willing to listen.
One of my senior leaders was here in India several months ago, and he was in a community hospital, and he picked up an instrument called an endo-GIA. It's a very sophisticated stapler used for transecting tissues laparoscopically. And the surgeon, was a very capable surgeon, said to him, "We love your product. I can fire this, we say fire this stapler 100 times over tissue, 30 patients, and it's as good on the 30th patient as it is on the first." And Bob, this guy, Bob DeSantis, who is this leader, said, "That's funny. We don't make a reusable stapler. All of our staplers are designed to be thrown away after one case." So what can we learn from that? What we can learn from that is we have to find ways to bring sufficient care, deal with that cross-contamination issue, but bring sufficient care to more people at a cost that is more effective. And it's going to take a whole lot of effort, and it's going to be a very interesting challenge for us in the technology field.